Hello and welcome. Thank you for coming to my presentation. My name is Anna Galazka and I am a lecturer in Management, Employment and Organisation at Cardiff Business School. That's Cardiff University in Wales, the United Kingdom. But I'm not a typical business scholar because in my work I study work and occupations and I draw on sociological theories quite a lot. And the work I would like to tell you about today is a project that enabled me to look specifically at the work of clinicians with an interest and expertise in the healing of wounds. I looked at the challenges that this group of clinicians faces in the medical community with regards to the status of their work and at the various ways in which these clinicians deal with the challenges of their work. The work of which I am going to tell you today has already been described and published in the journal Sociology of Health and Illness, and you can access the article for free in an open access format by clicking on the link that's visible on the screen. In this project, I approached wound healing as a new type of medical work, as a new medical specialism that, as I argue, has received an inconsistent level of clinical and academic attention. And in sociological literature in particular, wound healing has received very little academic attention. The references to wound healing that I have come across have been mostly in relation to the physically unglamorous aspects of wound healing work. There is an abundance of sociological literature on the so-called dirty work, that is work which can be physically quite unpleasant, socially problematic, or morally and emotionally difficult. And in sociological literature, wound healing tends to be only mentioned in the passing and mostly as a paradigmatic case of dirty work, predominantly in relation to nurses changing dressings and dealing with drainage from wounds. There is no acknowledgement in the sociological literature of wound healing as an independent, established clinical specialism in its own right. But what makes a medical specialism? Is it the jurisdiction over a specific domain of knowledge, that is, that exclusive right to practice in a specific field? Is it the science that comes with doing wound healing tasks? What does it mean for wound healing and wound healing professionalism? I think that there's a problem with the concept of jurisdiction, especially in relation to medical specialisms that are very multidisciplinary, that require the knowledge that has been created elsewhere. And this is the case for wound healing, because as we read in the publication from Professor Keith Harding from 2015, wound healing is a type of medical work that needs the input of a variety of specialisms of different clinical groups in order to deliver this coordinated care that addresses the underlying conditions that very often contribute to wounds being challenging, being non-healing. In my study of which I'm telling you today, I did an ethnographic exploration of a team of clinical academics with an interest and expertise in the healing of wounds. The study that I'm telling you about today was actually part of my doctoral research that looked at exploring the nature of clinician-patient relationships in wound healing, but I'm really only focusing on an aspect of my data that related to the project of professionalization of wound healing. My ethnographic research involved a qualitative exploration of the work undertaken in 3 specialist outpatient wound healing clinics that I refer to as Morgan Clinic, Bridge Clinic and Davis Clinic. I conducted just under 120 hours of observation and 19 interviews for this particular study, 12 with clinicians with an interest and expertise in wound healing who worked in the clinics, 6 with wound healing clinicians from other specialisms, as I say, or clinicians from other specialisms who were affiliated with the operations of these wound healing clinics, and 1 clinician unaffiliated with a team of wound healing clinicians who was not involved in practicing wound healing in any way. In my study, I wanted to understand how wound healing clinicians involved in doing dirty wound healing work seek to vindicate the nature of their work. The first strategy involved in standardizing wound care that I discovered was a local strategy. It was to do with the wound healing consultants from these clinics training other clinical groups, training nurses in particular, to do medical wound care work. The majority of wound care work in the United Kingdom tends to be undertaken by nurses. And in the clinics that I observed, this was indeed the case, in that nurses would very often manage the entire consultation on their own, from collecting patients from the waiting area to taking medical history, diagnosing, designing a carefully crafted program of care, and sending patient home with that plan with indicators for treatment success. So nurses had quite a lot of autonomy to work independently and out of the sort of normal traditional range. And this is very well captured in the quote that I'm showing you here on this slide from Amanda. Amanda, a nurse who told us that the unique skill that nurses in this clinic or in these clinics had was the skill of debridement. That was something that was unique to them, and that was not something that could be expected across the board. The second strategy that I distilled from my data was related to the sociologically fascinating project of continually contesting but also reaffirming the more traditional professional boundaries in medicine. Remember what I said to you about the majority of wound care being undertaken by nurses and the more dirty tasks of changing dressings and dealing with drainage from wounds being a nursey thing. Well, in the clinics that I studied, I observed that the opposite was quite often the case, with different clinical groups stepping in to do these tasks, to the amazement of some of the patients, as my ethnographic field note that I'm sharing with you on this slide is showing us. So there was this blurring of the boundaries between nurses and doctors, blurring of the boundaries that could be expected given the more traditional hierarchical system of a role division in healthcare. But in other situations, I witnessed quite the opposite. And I witnessed other clinicians actually reaffirming the boundaries between the work of wound care that is done by different groups. And we can see it in this quote from Dr. Kate, who was saying that when it comes to the sort of more medical tasks, that's very much done by doctors, whilst nurses do indeed have responsibility for a lot of the things that happen in a consultation. So here we see reaffirming the more traditional boundaries as in an attempt to perhaps reaffirm the fit of wound healing work with the medical establishment and with the medical mainstream. So we see the process of establishing the boundaries of what counts as wound healing or woundology as a process which is very fluid, which is not fixed at all, but something that sometimes departs from the medical mainstream and other times confirms the medical mainstream. So we see how the local strategy of standardizing wound care locally across different clinical groups is sometimes mixed with, conflicted by clinicians reaffirming the more traditional hierarchical divisions of work. Another way of speaking to the medical community in ways that were familiar to the medical mainstream involved speaking of wound care using the conception of wound healing as dirty work. Therefore, what I'm saying here, clinicians did not oppose the perception of wound healing as work that can be physically unpleasant, but quite on the contrary, this is something that they very much used to their benefits by showing the science that lies underneath the tasks that help to get patients better. As the quote from some shows us, it wasn't about how the wounds smelled or looked or made clinicians feel. The most exciting, the best part of the work done by wound healing clinicians was the looking underneath to actually make a difference to the quality of a person's life, looking underneath to heal the wound. And clinicians very much place the physically unpleasant aspects of their work within the boundaries of medical science, within the boundaries of woundology. And woundology was a discursive marker, very much used in the clinics in a humorous sort of way, but a discursive marker of the boundary of woundology nonetheless, to distinguish this type of work as something that was unique, as something that was special and scientific. So the discursive marker of woundology was an important aspect of the wound healing clinicians' professional project. The final strategy of professionalization, professionalizing wound healing work, which I discovered distilled from my data, related to asserting professional credibility of wound healing clinicians through research, through testing new treatments, testing new dressings. This was possible in the context of the clinics that I was studying because one of the hospitals was a teaching hospital, and the clinical groups of clinicians that I was studying were clinical academics. According to the wound healing consultant, approximately 12% of the patients who would come to the wound healing clinics were recruited, were simultaneously taking part in clinical trials. And having this set of research projects and having wound research happening alongside the clinical work was an important tool for increasing academic credibility of the work of wound healing clinicians, and especially in the early days of the clinics, when the clinics were first established in the sort of 1990s. But there was also great benefit for wound healing clinicians from different clinical groups that were involved in doing wound care work, because it enabled other clinical groups, such as nurses, to work outside of the boundary of or outside of the normal range of what they would be doing otherwise. So all clinicians involved in clinical research could read journals, could write for journals. Some could teach about what they've read, some could teach about what they've done in the clinic. So there was this constant process of upskilling all clinical groups in the clinics through combining clinical practice with medical research. So what does it mean for the professionalization of wound healing? In my study, I argue that the process of boundary demarcation for wound healing is a process which involves simultaneous domination and inclusion. It is a process that involves containing the knowledge of wound healing clinicians within the boundary, but at the same time, the boundary itself is porous, so it enables the influx of the work of other clinical groups, of the knowledge of other clinical groups into wound healing, and the other way around. This is very important for a multidisciplinary professionalism, multidisciplinary medical specialty, such as wound healing. But a question that emerges perhaps relates to what is the jurisdiction over? And what I claim in my research is that the jurisdiction for wound healing or woundology comes from sitting in the middle of the process of coordinating the care of patients with wounds across different specialisms, across the care of clinicians with expertise in different fields. So wound healing is something that sits in the middle and coordinates the care of these patients. Thank you very much for listening. Please email me if you have any questions on galazka@cardiff.ac.uk, or you can follow me on Twitter. I will be happy to now take any questions that you might have. Thank you.